Imagine going to a doctor with, like, excruciating pelvic pain, and they just examine you under these bright lights, shrug, and say, well, everything looks completely normal.
Yeah, which is just incredibly dismissive.
Right. But for an estimated 14 million women in the U.S., this isn't some hypothetical scenario.
Yeah.
It's just a daily, profoundly isolating reality.
Because the pain they're experiencing is undeniably real, you know. But since the underlying injury remains completely invisible to the naked eye, the patient's lived reality is just frequently questioned by the medical establishment.
And that's exactly why today we are cutting straight through that diagnostic ambiguity. We are doing a deep dive into a stack of recent medical literature, highly structured clinical trial designs, and narrative syntheses.
Right.
And the mission here is to answer one very specific clinical question. When is oral gabapentin or pregabalin clinically indicated to treat the centralized neuroproliferative pain pathways of refractory vestibulodynia?
Which is quite a mouthful, I know. But we're basically examining provoked vestibulodynia, a condition you'll often see referred to in like older medical literature as vulvar vestibulitis. And women navigating this condition, they typically endure this awful gauntlet of non-evidence-based treatments, just bouncing endlessly between gynecologists, dermatologists, and, you know, pain management specialists.
Oh, absolutely.
So understanding the exact biological origin of these pain pathways is really the only way to pivot toward targeted, evidence-based relief for you, for the patient.
Right. And to give some baseline here, the clinical literature defines provoked vestibulodynia specifically as superficial vulvar vestibular pain that is triggered by direct touch.
Yes, exactly.
So we are talking about severe, debilitating pain upon vaginal penetration, or, I mean, even an action as routine as inserting a tampon.
Yeah.
In fact, the clinical trials we were reviewing today, they actually rely on a validated tampon test. Right? To measure this pain intensity objectively across different patient populations.
Yeah, and utilizing a standardized provocation like that is just absolutely essential for rigorous research.
Right, but you need a baseline.
Exactly. To establish a baseline and accurately measure whether a neurological treatment is working, you need a reproducible physical trigger. Because for decades, the prevailing narrative just dismissed this pain as psychogenic.
Just because there was no obvious injury.
Right. Simply because there were no overt signs of infection or, like, macroscopic trauma. But the current literature completely shatters that outdated paradigm.
Thank goodness.
Yeah, it points to a neuroproliferative subtype of dyspareunia.
Okay, so neuroproliferative. The tissue is physically, fundamentally changing, right?
Yes.
Like the pelvic peritoneum and the vulvar vestibule in these patients, they show a significantly higher density of both sensory and autonomic nerve fibers when compared directly to control tissue. So under a microscope, the tissue is highly hyperinnervated. Basically, there are literally extra nerves growing there.
Yeah, literal extra nerves. And this excess nerve growth is driven primarily by an overexpression of nerve growth factor, or NGF.
NGF, got it.
Right. So nerve growth factor binds to specific receptors on nerve endings, triggering this signaling cascade that actively promotes the survival, the maintenance, and just the rapid sprouting of nociceptors.
And nociceptors, those are our pain-sensing nerves.
Exactly. But this doesn't happen in a vacuum, right? It works in tandem with localized inflammation and hyperactive mast cell activity.
Wait, mast cells, aren't those typically associated with, like, allergic responses and wound healing? Like releasing histamine and cytokines?
Yep, they sure are. But in this neuroproliferative state, those mast cells essentially fertilize the tissue.
Oh, wow.
They release this constant stream of inflammatory mediators that continually sensitize these newly sprouted nerve endings. And that drastically lowers the threshold required for them to fire a pain signal to the brain.
Okay, let me make sure I'm wrapping my head around this. It sounds like a home security system where a rogue electrician accidentally installed like 100 hypersensitive motion sensors in a single tiny room.
That's a great way to look at it.
And so you open the door a crack and every alarm in the house goes off simultaneously.
Yeah, exactly. But it gets worse. Because not only are there far too many sensors, but the central alarm system itself, you know, the spinal cord and the brain, it eventually gets permanently stuck on high alert. Because those local nerves in the vestibule are hardwired to the central nervous system. When you have a constant, unrelenting barrage of intense pain signals firing from these localized peripheral nerves over a long period, it triggers a phenomenon known as central sensitization.
So the signals are just bombarding the dorsal horn of the spinal cord.
Continuously, yes.
Yeah.
And this constant bombardment actually unblocks specific receptors in the spinal cord, leading to a massive influx of calcium into the neurons.
Which changes how they function.
Right, it creates a state of long-term potentiation in the pain pathways. The central nervous system essentially rewires itself to expect and amplify the pain.
It's like the volume dial on the pain signals just gets stuck at 10.
Yeah.
Shifting this from a localized acute inflammatory response into a fully chronic neuropathic condition.
Exactly. And then the patient develops what's called dynamic allodynia.
Right.
So a physical stimulus that should feel completely benign, like a cotton swab or a feather lightly brushing the vestibular skin, is interpreted by the brain as a blowtorch.
Oh, God.
Yeah, the primary amplifier of the pain is now central rather than local.
Okay, so when the pain centralizes like that, standard localized treatments inevitably hit a wall, which makes sense. But even standard systemic interventions fail at pretty frustrating rate, don't they?
They really do.
Because historically, clinical guidelines suggested, starting with tricyclic antidepressants, TCAs like amitriptyline or desipramine.
Yeah, and earlier observational studies painted a remarkably optimistic picture of using TCAs for provoked vestibulodynia. But when researchers finally subjected these drugs to rigorous, randomized controlled trials,
The RCTs.
right, the RCTs, the results revealed a sharply lower efficacy rate because observational pain studies frequently fail to account for the natural fluctuation of chronic pain syndromes.
Like how the pain just naturally ebbs and flows on its own.
Exactly. And they also struggle to isolate the powerful placebo effect that's inherent in receiving a new systemic treatment from an empathetic physician.
Right. You get a new pill from a doctor who actually listens to you. You might feel better for a bit just from that.
Yeah.
But double-blind, placebo-controlled trials effectively strip away that physician-patient bias. And once that bias was removed from the equation, the RCTs proved that TCAs leave a massive percentage of these patients refractory, meaning they are completely resistant to standard care.
Yep. And at that specific juncture, because the centralized vestibulodynia now behaves biochemically like chronic neuropathic pain, gabapentin emerges as a primary clinical indication.
Okay.
Clinicians already rely heavily on gabapentin as a first-line defense for severe neuropathic conditions. Things like postherpetic neuralgia and painful diabetic neuropathy.
Wait, hold on. Let me push back on this for a second.
Sure.
If you're telling me the root biological problem is a tiny cluster of extra nerve fibers in the vestibule driven by local mast cells, prescribing a systemic pill that bathes your entire brain, and spinal cord medication makes no sense.
Well,
I mean, isn't that using a sledgehammer to crack a nut?
I get why it seems that way, but the nut is no longer just located in the vestibule.
Because of the centralization.
Exactly. Because of that wind-up phenomenon we discussed, the central nervous system is now actively generating and sustaining the pain experience. So numbing the surface tissue won't stop the spinal cord and brain from severely amplifying every incoming tactile signal.
Right, the alarm system is already blaring.
Yes, so gabapentin works by binding to specific alpha-2 delta subunits of voltage-gated calcium channels in the central nervous system. By blocking these calcium channels at the presynaptic terminals, it throttles the release of excitatory neurotransmitters like glutamate.
So you actually need that systemic sledgehammer to calm down the central hyperexcitability.
You really do.
And the sources highlight a critical dual benefit to this systemic approach as well, because women with provoked vestibulodynia often develop pelvic floor hypertonicity, right? It's this natural guarding reflex where the muscles of the pelvic floor spasm and tighten to protect against the anticipated pain of penetration or touch. And the chronic nature of the pain also deeply alters cognitive pain patterns, leading to profound anxiety.
Right, and oral gabapentin offers potent anxiolytic, meaning anti-anxiety and anti-spasmodic effects alongside its primary neuropathic mechanism.
So a systemic drug tackles the pelvic muscle spasms, the central pain loops in the dorsal horn, and the generalized anxiety simultaneously.
Exactly. It is a multi-pronged, a pharmacological attack on a multimodal physiological problem.
Now, the literature details a very specific 18-week, multi-center, randomized controlled trial studying an extended-release form of gabapentin, known clinically as Grelise, I believe.
Yes, Grelise.
And they were utilizing incredibly high doses, ranging from 1,200 to 3,000 milligrams a day.
And the methodological rigor of that specific trial is worth highlighting, especially compared to those older TCA studies. They utilized a two-treatment, two-period crossover design.
Okay, break that down for us. What does a crossover design mean for the patient in the trial?
So patients received the active gabapentin, then tapered off completely to wash the drug out of their system, and then crossed over to the placebo arm, or vice versa.
Oh, wow.
Yeah, and they did this without ever knowing which pill they were taking at any given time.
So this means every single patient serves as their own baseline control, which has to drastically reduce the statistical noise you usually encounter when you're comparing two entirely different groups of people with wildly varying baseline pain thresholds.
You nailed it. Parallel group designs really struggle with chronic pain because of that massive intersubject variability, but the crossover design eliminates that variable.
That's brilliant.
It is. And the trial also included dedicated titration phases to safely build up the systemic dose, stable maintenance phases, and proper taper phases.
So it was incredibly rigorous.
Very. The explicit objective was to generate undeniable, evidence-based data proving that for refractory centralized cases, systemic gabapentin significantly reduces pain as measured objectively by the tampon test.
Right. Now, there is a citation in our stack today detailing a really compelling case study of a 62-year-old woman with a 20-year history of vulvodynia.
Oh, yes. That case is fascinating.
2 full decades of unremitting centralized pain.
Yeah, and she finally achieved complete remission using pregabalin, which is a drug that operates on the exact same calcium channels as gabapentin, but possesses slightly different pharmacokinetic properties and bioavailability.
So a slightly different tool doing a very similar job.
Exactly. And cases like this highlight the profound chronicity of refractory vestibulodynia. Decades of neural rewiring create deeply entrenched, heavily fortified, centralized pain pathways.
You cannot simply undo 20 years of central sensitization with a mild intervention.
No, you can't.
It requires heavy-hitting systemic neuropathic drugs to disrupt the calcium channels and break the cycle. But swallowing up to 3,000 milligrams of a drug designed to cross the blood-brain barrier and depress the central nervous system, that comes with a massive physiological cost.
A huge cost, because the central nervous system regulates our entire conscious experience, our coordination, our alertness. And the sources outline frequent, severe, systemic adverse events associated with these therapies. The most commonly reported are somnolence, which is profound sleepiness, dizziness, and peripheral edema, which is swelling in the limbs.
So you're essentially trading intense, localized pain for feeling like you're trying to walk and think through thick molasses all day.
Yeah, and for many patients, they find that trade-off entirely worthwhile just to escape the excruciating, relentless pain.
Which says a lot about how bad the pain really is.
Absolutely. But others find the cognitive fog and physical lethargy completely intolerable. It severely hinders their ability to work, socialize, or, drive safely.
Well, if the side effects of swallowing a pill are that debilitating, why aren't researchers just formulating a cream and having patients rub it directly on the localized pain site in the vestibule? Just bypass the brain entirely.
It's a great question, and formulating topical gabapentin is actually a major frontier in current research for that exact reason. Bypassing the stomach, the liver, and the blood-brain barrier to deliver the active neuropathic agent directly to the site of neuroproliferation, it works exceptionally well in controlled animal models.
Right, there was one specific study on a chronic sciatic nerve constriction injury model in animals, right?
Mm-hmm.
And it demonstrated that applying a topical gabapentin gel alleviated the allodynia and hyperalgesia beautifully without all that systemic lethargy.
Yeah, but translating that success to human evidence for topical gabapentin in vulvodynia remains highly problematic. The narrative synthesis reviewing the available studies on topical treatments in women reveals massive, glaring methodological holes.
Like what?
Well, the human studies suffer from incredibly small sample sizes. They lack proper randomization, which introduces massive selection bias. And crucially, they frequently lack control arms entirely.
Oh, wow. So they aren't even comparing it to a placebo cream.
Right. And evaluating a chronic pain condition where baseline symptoms naturally ebb and flow, you require a robust control arm. Without a placebo group to compare against, you cannot definitively attribute any symptom improvement to the topical drug rather than just the natural physiological course of the disease.
Not to mention the vehicle itself, the soothing cream or gel base. That alone can produce a significant placebo effect on irritated tissue.
Exactly. Furthermore, some of the reviewed studies utilized compounded creams that mix gabapentin with other active ingredients.
Oh, so making it totally impossible to isolate which specific pharmacological component was responsible for any observed clinical benefit.
Precisely. Synthesizing all of this data leads us to a harsh clinical reality. Topical gabapentin is a brilliant concept theoretically, and it is desperately needed to help patients bypass the dizziness and somnolence.
Right.
However, lacking robust, double-blind, placebo-controlled human trials, it just cannot currently replace systemic therapy.
Mhm.
When central nervous system pathways are deeply entrenched, and the patient has failed standard therapies like TCAs, oral gabapentin or pregabalin remains the clinically indicated intervention.
Even despite the known systemic trade-offs.
Yeah, you have to utilize the tool that is actually backed by rigorous crossover trial data.
So bringing it all together, we set out to understand exactly when oral gabapentin or pregabalin is clinically indicated for this complex condition. And the medical literature provides a very clear mechanistic map.
It really does.
These systemic medications are clinically indicated when provoked vestibulodynia transitions from a local inflammatory response, driven by those mast cells and extra nerve fibers sprouting in the tissue, into a centralized neuropathic condition characterized by dynamic allodynia.
Specifically when the patient is refractory to initial treatments, yeah.
Right.
And grasping this exact mechanism, the literal proliferation of nerves and the subsequent biochemical hijacking of the central nervous system is just critical for anyone navigating this condition.
It really is.
It empowers you with the concrete knowledge that your pain has a measurable biological origin. This shifts the entire paradigm away from enduring nonspecific, ineffective treatments and points directly towards seeking out targeted, evidence-based neuropathic therapies.
And it really forces the broader medical community to look past macroscopic tissue and actively address the microscopic neurochemical chaos happening underneath.
Absolutely.
But consider this. If this entire cascade of chronic centralized pain begins with nerve growth factor binding to receptors and causing extra nerves to sprout in the pelvic tissue, if that is the root cause of the entire home security system going haywire, what if future medicine didn't just suppress the central nerve signals with heavy systemic drugs? What if researchers actually figured out how to switch off the nerve growth factor before those extra nerves ever take root? What if we could just stop the installer before the sensors are ever placed?